Tonight on Nova, to the old weapons in the war on cancer are being added new treatments, new strategies, new understandings of cancer's cause to fight today's battles in the war on cancer. In this second Nova special, we search for signs of progress against one of the major killing cancers. Join Jane Pauley of NBC News for Breast Cancer, Turning the Tide.
Major funding for Nova is provided by this station and other public television stations nationwide. Additional funding was provided by the Johnson & Johnson family of companies, supplying healthcare products worldwide. And by Allied Signal, a technology leader in aerospace, electronics, automotive products, and engineered materials.
One in every 11 women in America will get breast cancer in her lifetime. Right now, a third of them will die of their disease. Until recently, it was the leading killer of women. The only reason it isn't today is that more women are dying of lung cancer. In the ongoing war on cancer, there have been some striking successes and many disheartening stalemates. The successes have been against less common cancers like childhood leukemias. The failures have been in the major killers like lung cancer, and until recently, breast cancer. But right now, new insights into what cancer is coming from the laboratory, added to the refining of existing cancer treatments, have begun a revolution in breast cancer that suggests the first flickerings of a larger victory against cancer in general. It's a series of revolutions, really, in diagnosing, managing, and treating breast cancer, in understanding what makes it so deadly an enemy, in searching for ways to prevent it. None of these revolutions is won, but there are signs that in the battle against breast cancer, the tide is turning. Mary Reeves is 29, very young to have breast cancer. She's a few minutes from the operating room. For her, the fact that a revolution's underway in breast cancer treatment has meant confronting bewildering choices at a terrifying time.
Patients would like you to know the answers. I mean, it's not just that doctors like to be gods, it's that the patients want you to be God. If you have breast cancer, you want to go to a physician who will say, I can cure you and this is how I'm going to do it and you'll be fine. The problem is it doesn't work.
Dr. Susan Love is a surgeon, a profession whose role in treating breast cancer has changed dramatically in the last few years. Changed not only because what surgeons used to do didn't work, but ironically because what they do today often doesn't work either, at least in saving the lives of their patients.
You look like so good of a doctor. I can just see how easy it is going to be.
Good, great.
Because you can see it.
It will be a piece of cake.
Oh, good.
Okay. Everything's going to be just fine. So I'm going to go get this stuff set up, and we'll be back to get you shortly. Okay? Great.
Surgery has been the frontline weapon against cancer for 2,000 years, against breast cancer for a century. Its role today is different thanks to new insights into the nature of breast cancer, the demands of patients, and because women themselves have begun to occupy male-dominated professions.
You're Mary, huh? I'm Mary, too. Okay, Mary, you'll be feeling a little sleepy now.
In this operation at Boston's Beth Israel Hospital, both anesthesiologist and surgeon, as well as the nurses, are women. The only male on the team is an intern.
Have good dreams.
Let's go.
We're going to take good care of you, and everything's going to be just fine.
Hey, Mary.
It's okay.
Mary?
Mary Reeves' journey to the operating room began a few weeks ago when her boyfriend Joe discovered a lump in her right breast.
If you don't have ribs, your heart falls out. It's very messy. Check this side. Relax. There, this is that lump under your arm we're talking about.
Yeah. which the doctor laughed off, said it's just an irritation. And
Well, it's hard to know because you are allowed to have lumps under your arms.
Yeah.
Just from lymph nodes without having to have breast cancer.
The reason the breast cancer surgeon's role has changed is that the lump that usually signals the disease is by this stage almost unimportant.
I would say the lump was high. It was over here.
Having breast cancer in your breast doesn't kill you. You can have a lump as big as a basketball, and it would make it difficult to buy clothes, but it wouldn't kill you. What kills you is having breast cancer cells in other parts of the body that are more important. Lungs, liver, bones, brain, areas where it takes up room and interferes with vital functioning. So the important battle in breast cancer is not getting rid of the cancer in the breast, it's getting rid of any potential or any microscopic cells that might be elsewhere in the body. One isn't better than the
It was the fact that cells had escaped from the primary tumor that 10 years ago killed Mary's mother from breast cancer, at a time when the entire focus of treatment was on surgery.
right? The old theory about breast cancer was that it would start in the breast, get slowly bigger, go one by one up the lymph nodes under the arm, and then when it got to the last lymph node, then it would go to the whole body. So everybody thought, aha, we got to rush right in there real fast, we got to do a big operation, and maybe, if we're lucky, we can get around it, you know, we can prevent it from getting out. And that was all the mastectomies were based on that.
Yeah.
And all, I'm sure your mom probably
And that's
went through
probably
that.
what I had in my mind.
Yeah, I'm sure that, you know, where they'd say you go straight from the doctor's office, straight to the operating room, slam, bang, you know, get big operation and maybe you could get it. The trouble is that never worked very well. And as happened, did your mom have a mastectomy for
Yeah,
breast
she
cancer?
did.
You see, she had a mastectomy and she still died of breast cancer. So
Right.
obviously there's something wrong with that theory, and all the rushing in the world doesn't necessarily make a difference.
The theory that breast cancer cells escape by way of the lymph nodes goes back to the last century. Lymph nodes are the sites of pitched battles between the body's immune system and foreign invaders like bacteria, as well as escaped cancer cells. The American surgeon, Dr. William Halstead, believed that by removing the entire breast and all accessible lymph nodes, he could get rid of all cancer cells. The radical mastectomy remained the standard treatment for 90 years. Yet still more than 50% of patients died. By the 1970s, some surgeons couldn't help drawing the obvious conclusion.
And they kept thinking, well, maybe if we took a little bit more, if we got just a little bit further, then it would make a difference. Maybe it's just I didn't get that last lymph node, and so I'll go a little higher. You know, I'll take a little more tissue out, and then I'll save the person.
One of these surgeons, convinced that more would mean better, worked here at Italy's National Tumor Institute in Milan. He persuaded several European colleagues to begin a clinical trial.
At that time, we are convinced that this enlarged operation, more extensive than the original Holst operation, would improve the prognosis according to the original principles. And so we did a very large, extensive study, a clinical trial in Europe, with 5 institutions collaborating, and we collected some 1,500 patients. And after a number of years, 5 years, we discovered that this extensive operation did not improve the prognosis. Therefore, we started thinking that our extensive approach was wrong. And this was the beginning of the total modification of my approach to breast cancer.
Veronese reasoned that if more surgery made no difference, less surgery might not either. As it happened, he'd already performed a more limited operation on a few patients seeking an alternative to mastectomy, unlike most of his colleagues.
They refused to treat patients if they refused mastectomy. They said, I don't want to take responsibility to make a wrong operation, a wrong treatment, so please go away, I don't want to treat you, to see you anymore. But it was a very, in my opinion, was a very bad type of position. And I had a totally different type of position towards these women, and when women asked me to avoid operation, so I started to do this limited operation, informing her that it was just an attempt without any real possibility of cure. This was the general belief. And so I accumulated some 15 or 20 cases treated in this way. And surprisingly, when I went back to look at the records, I found that the survival was not bad, after all.
The operation Veronese pioneered, he called a quadrantectomy, today often called lumpectomy. It removes just the tumor and the tissue immediately around it. The procedure is combined with radiation treatment designed to kill any cancer cells remaining in the breast.
In Italy, at the beginning, there was no acceptance, and a sort of skepticism was the general feeling. Then, little by little, from 1981 to today, there was an increasing acceptance of this operation. And today, nearly 50% of the patients with small tumors are treated with a conservative procedure in Italy.
The American surgeons said, but that's Italian women. You know, Italian breast cancer, you can't believe that. And they kept on doing their modified radicals. They're fairly conservative people, and I think they tend to say, I've always treated people this way, it works, I'm not going to change until you show me that something's better. And of course, none of the data shows that lumpectomy or quadrantectomy and radiation is better than mastectomy. What it shows is that it's equal.
Lumpectomy and radiation has now been shown to be equal to mastectomy in several large-scale clinical trials in the United States. Mary Reeves chose lumpectomy. Although the operation is smaller, the job of the surgeon is trickier than a mastectomy.
One of my patients told me that breast tissue is like women in general. Soft and smushy on the outside and tough as can be on the inside.
Dr. Love's task is to ensure none of the tumor remains in the breast while removing as little tissue as possible.
I'm just outlining this for the pathologist so that they know where the tissue was taken from. And then they'll look at it, and if it looks like there's cancer near one of the margins, they'll call back in and tell me, and I can take a little more tissue out. So. Now try to stitch. So it's probably okay. Okay, great. Yeah. Okay, and then there'll be some lymph nodes coming soon too. Thank you, bye. Good, so the margins are grossly clean. They don't see any tumor at the margins, so that's good, so we can just continue on our merry way. And the second trick is figuring out how to put it all back together again so that it looks reasonably cosmetic, having taken out a fair amount of tissue.
Mary Reeves will emerge from this operation with her breast almost intact. Yet, despite the evidence that lumpectomy plus radiation is no worse and no better than mastectomy, less than a quarter of the women eligible for the lesser operation get it. The great majority are still treated with mastectomy.
Doing a mastectomy is amputating a part of your body, and it's a mutilating operation. There's no way around it. And granted, any of us could put up with it if you said, that's the thing that's going to save your life. There's not a woman who wouldn't do it. On the other hand, if it's not going to save your life, and if it's not going to add anything to your survival or your local control, then why should you have a mutilating operation? You know, it's much nicer to live intact.
The reason neither surgical procedure may be enough to save a woman's life is that her breast cancer has been growing for 8 to 10 years before it was detected as a lump, and it's been shedding cells into her body via the bloodstream all that time. The escaping cells are battled by the body's immune system, a battle whose success can be roughly judged by removing and checking a few of the lymph nodes under her arm.
What we want to figure out now is what's the balance of power between her body and her cancer. And if there are no cancer cells in any of the lymph nodes, then we would consider that there's a better chance that her body's taking care of whatever cancer there is around, and that she doesn't need any further therapy such as chemo. If the lymph nodes are positive, then that means that there's a higher probability that there might be cancer cells elsewhere.
A month ago, Doreen Emery had a mastectomy. Her lymph nodes were positive, meaning there's a high probability, perhaps 70%, she has cancer cells elsewhere. Eventually, in a few months or a few years, those cells would kill her, unless they can be hunted down and destroyed. Today they can be, and it's here that for the first time a breast cancer treatment is actually saving, or at least extending, lives. The weapon is chemotherapy, drugs that are more poisonous to cancer cells than normal cells.
This is the one that I was telling you.
Proving that chemotherapy works was difficult. There's no way to tell in an individual patient even whether there are escaped cancer cells, let alone whether the drugs are killing them. Only because thousands of women like Doreen have taken part in clinical trials has chemotherapy been shown statistically to extend the life of node-positive women by an average of 4 to 5 years. A researcher involved in these trials is Dr. Craig Henderson.
To what extent it exists. Now, we think that being able to prolong life on an average of, let's say, 5 years, that number, as I said, is going to vary, but let's just say it's an average of 5 years, is a big step forward. Most of us, if we can, say, invest 6 months and get 5 years back, more than the bank's going to give you, right? It's a pretty good investment. But I don't think we want to stop there. If we can invest 6 months or 4 months, let's say, and get 10 years back or 20 years back or get a cure, I think that's ultimately where we want to go. So we're trying continuously to find new programs that we hope will be better.
A new, still experimental chemotherapy program is about to be tried on Doreen. She is informed of all the possible side effects of the new drug combination, which is likely to be more toxic than the standard one. The purpose of the current trial is to try out different doses of the drugs.
The question which we're asking is a high dose more effective than a lower dose? Is the lesser toxicity associated with a lower dose going to prove to be advantageous because it'll be more tolerable? So therefore, whichever arm of the study you're on, you have a chance of winning and you have a chance of losing. One case you lose because of more toxicity. One case you lose because of some possible decrease in efficacy. Those are questions we don't know, and we feel very, very firmly that those have not been answered with any scientific information. And the only way it's going to be answered is by doing a scientific study. Should we find out what you've gotten?
To make that study scientific, Craig Henderson's own bias, he favors the low-dose combination, mustn't influence the decision about which dose Doreen will get. So the choice is made by a statistician at the other end of the phone, simply pulling the next card in a randomized sequence.
600, you mean? 600, 16, 600. Okay, very good. Yep, bye-bye. Okay, so that's the high dose.
Doreen's treatment begins. She'll never know if the high dose of the drugs did her personally any good. She could be one of the 30% of node-positive patients who have no escaped cancer cells, in which case the drugs and the accompanying sickness and hair loss are for nothing. She's cured already.
Now, walk with your fingers. Go up, up.
Mary
up,
Reeves' chances of being cured already are better than Doreen's. Her nodes were negative. Statistically, that means there's only a 25% chance some cancer cells escaped before surgery. But that still means that 1 in 4 node-negative women die of their disease. And the problem is, there's no way to tell who the unlucky ones will be.
Okay, this is a case of Mary Reeves.
Looking at slides of Mary's tumor can give pathologist Jim Connolly some clues as to how likely it is that the tumor shed cells through the body before it was removed.
Nuclei and a very high mitotic rate, plus a lot of necrosis, we would say that she probably has substantial likelihood for developing metastatic disease, even in the face of negative nodes.
So she'd probably fit in that category of node-negative patients that still might have micrometastases, where you might want to give chemotherapy anyway.
Probably the medical oncologist here wouldn't give her chemotherapy. Some would and some wouldn't. I mean, she's not a clear-cut.
This is the single hottest issue in breast cancer right now, whether or not to give chemotherapy to node-negative women like Mary.
Factors that people have used.
Yeah, I think that's controversial, but I still would put her, from various studies, at probably 30% risk for developing distant metastases.
So she might be someone that's worth at least thinking about giving chemotherapy to in a node-negative situation. Now, it's very controversial, so what you'd want to do is discuss it with her and discuss the options with her and let her be a partner in the choice.
We know there's no big cancer cells anywhere else because all the tests were negative. But it's these 1 or 2 microscopic cells here or there that are the ones that are going to get you if anything's going to get you. So I think that it's not crazy to think about, even though the lymph nodes are negative, to think about doing chemotherapy anyway. It's not fun, but it's not awful.
Yeah, that's what the other doctor was saying.
And if we miss it now, at least in the current state of the art, we've missed it. And that's why I think, and I don't give chemotherapy. I'm a surgeon, so I'm sort of, usually surgeons are biased against chemotherapy.
Yeah, I was going to ask you that. What would you do?
I'd probably have chemotherapy.
What is standard therapy?
Mary has to confront the fact that there are no sure answers or unanimous advice in a case like hers.
Final decision. If you were to go from hospital to hospital, let's say you got a second, a third, or fourth opinion, which a lot of patients do, you would find that some doctors would say, no, I wouldn't give you anything further. Other doctors would say, I think you should have a year or 2 of chemotherapy. Okay, well, when some doctors say one thing and some doctors say another, it means that nobody really knows the right answer.
The woman herself has to decide. If 5 years from now we're giving everyone node-negative chemo, I don't want the patient to say, you told me I didn't need to have it, and you deprived me of having this treatment, which might have saved my life. I want them to know exactly where we are in the science and the state of the art, and then they have to decide. It's hard, but it's your body, and that's part of being a grown-up, is deciding things with inadequate information.
Mary begins her radiation treatment. It's designed to kill any cancer cells left in the breast. It can't reach escaped cells. Only chemotherapy can do that. Mary's conundrum, whether or not to have chemo, is now faced by the majority of breast cancer patients. A consequence of the lymph node tests giving only the odds and not a straight yes or no answer to the question, am I cured already? Or are there cancer cells left that may one day kill me?
Now, the next logical question is, well, why not just give it to everybody? But the problem is chemotherapy has a lot of side effects. It also may well have long-term risk factors that we don't know about 20, 30, 40 years from now. So you would hate to give these powerful poisons to people who really don't need them at all. And if 80% of women aren't going to need them, you really don't want to just hand it out to everybody. So it's very important for us to be able to figure out a more precise method of deciding who will benefit from it and who wouldn't.
Many laboratories, like this one at the University of Texas, are now working on ways to tell more accurately if a woman's cancer will recur. Here, a laser beam scans tens of thousands of cells from an individual tumor in just a few seconds, measuring how fast they're growing and dividing. The goal of this and other approaches is to get to the cancer cell itself and no longer rely on what's happening in the lymph nodes.
A tumor doesn't behave aggressively because a woman has extra lumps in her axilla or armpit. There has to be a biologic reason for it. What's that biologic reason? For the first time, with the advent of molecular biologic techniques, we can begin to ask those questions. What's going on at the level of the gene that makes this cell and this particular tumor behave in this way?
This test tube contains DNA, the material of our genes. Some human cancers have genes that have gone bad. They're called oncogenes.
Oncogenes provide us with the roots of cancer, the explanations for how cancer begins. They're the genes inside cancer cells which orchestrate the entire malignant process. In other words, we think that amidst the enormous genetic complexity of a cancer cell, there lay a small number of genes which direct the cell to behave abnormally.
Dr. Robert Weinberg was one of the first scientists to identify oncogenes and to find out how they make cancer cells behave abnormally. One oncogene discovered by Weinberg in a rat brain tumor turns out to disrupt the process which tells cells when to grow and divide. By making the cells grow when they shouldn't, the oncogene causes cancer. Here's how it works. All cells have genes that make molecules known as receptors. They sit at the cell surface and respond to signals from the outside by sending a message back to the cell nucleus that it's time to grow and divide. The oncogene in rat brain tumors makes a slightly altered receptor that's stuck in the on position, so that the cell keeps growing even when there's no signal telling it to. Variations on this process are now known to be the cause of many cancers. Oncogenes may help explain cancer, but can they help cure it? Today, the answer suddenly seems yes, because the remarkable fact is that the same oncogene Weinberg found in rat brain tumors turned up in human breast cancers.
There are tumors that have a single copy of the gene, and that's a much less intense signal. And there are other tumors that have multiple copies of the gene, and they have much higher signals. So there are much more intense bands here. So this band represents what the gene looks like in this analysis. And the intensity tells us how much of the gene is there in a given tumor.
Slayman wondered if his discovery that different patients had different amounts of the gene reflected any difference in how their tumors behaved. He went to the University of Texas at San Antonio for help, because here Dr. William McGuire has a unique resource.
If you're going to look at actual human tumors, the critical thing is a source of tumors, and that's what the San Antonio group has in spades. Dr. McGuire has accumulated over between 15 and 18 years a large number of tissues from patients with breast cancer, and has amassed this large tumor bank, and he's amassed an enormous amount of clinical information.
Freezers are scattered through the corridors, each packed with frozen fragments of breast cancer sent here from all over the country.
And now we have over 10,000 specimens that we've squirreled away that are now enormously valuable. I mean, we're getting tons of information out of them. Often people said, "Can we please clean out the freezer? It's full." I said, "No, let's buy another freezer."
Tumors removed from patients are frozen and sent here to be processed and stored. Among the 10,000 samples are thousands of tumors that eventually killed the women they came from. Thousands of others are from women still alive. This is the sample's real value. What happened to their original owners is stored in the computerized data bank run by Gary Clark.
Well, this represents a premenopausal 43-year-old woman who is stage 1. She has 0 out of 16 nodes positive, a 2-centimeter tumor. After her modified radical mastectomy, there was no adjuvant therapy applied. And she's doing quite well. She's disease-free after 79 months, still alive. This patient is very similar in demographic characteristics to the last patient. She's 47 years old, also stage 1, 0 out of 10 positive nodes, and again a 2-centimeter tumor. She also had a modified radical mastectomy, but no adjuvant therapy. However, this patient recurred at 18 months and died just 7 months later.
This kind of information meant Dennis Slayman could get tissues from the San Antonio Bank, measure their oncogene levels, then see if that correlated in any way with what happened to the women the tumors came from.
The tumors were sent to us without the clinical information, so we wouldn't be biased in our analysis. Once we had the data compiled, we sent it back to San Antonio. Gary fed it through the computer system and let us know that it appeared that amplification of the gene correlated with patient behavior outcome.
What the computer revealed was that women who died of their disease had higher levels of the oncogene than those who survived. It makes sense biologically. The more oncogenes present, the more receptors are made, and the more grow and divide signals the cell will get from its environment. It could turn out to be a fundamental reason some women's breast tumors are more aggressive and more likely to spread than others. And it's this hope that's leading Slayman, McGuire, and others to search for ways to simplify the presently laborious task of measuring how much oncogene is present in a breast cancer cell. Because a rapid test for oncogene levels could make sampling lymph nodes unnecessary and provide a much more accurate way to tell if a woman would benefit from chemotherapy. But oncogenes could provide more even than an immensely valuable diagnostic tool. Already, researchers are figuring out ways to block their action or use them as targets for toxic drugs in the hope of devising entirely new therapies for breast cancer.
So I think that we're going to definitely see a change in the next 5 to 10 years with how we treat cancer. Right now we're doing it in a very crude fashion, albeit the best fashion we have available. Once we begin to understand what's going on at the molecular level, we can more carefully pinpoint therapy, more carefully design treatment, and hopefully more effectively treat cancer.
This is the
Oncogene research is just one of many approaches now being taken to understanding the basic mechanisms of cancer. At the National Cancer Institute, scientists are studying breast cancer cells to see how they escape the primary tumor and invade other organs, the process of metastasis that actually kills breast cancer patients. The NCI research has identified 3 crucial steps in the process the cells use to escape into the patient's bloodstream and establish themselves elsewhere. The escaping cell has first to attach to the membrane surrounding the blood vessel. Then it punctures the membrane with a powerful chemical. Finally, it squeezes through the hole. After traveling through the body, it uses the same 3 steps to get out of the blood vessel and into the organ it's invading. The researchers have identified specific molecules associated with each of the steps and hope to block their action or use them as targets for toxic drugs. The sense that real breakthroughs are being made in the laboratory is even shared by some physicians.
And I think it's going to end up somewhat like tuberculosis, that we'll find a very simple answer, and that all of these elaborate schemes of treatment we've developed of surgery and chemo and radiation will become obsolete, and we'll only use them on a few cases that happen to get by. But the answer, I think, really is in molecular biology and genetics, and not at all in the level that I'm working.
But perhaps the most important breakthrough that could be made in breast cancer is at another level again. Not in treating the disease, but by preventing it. In rural China and in other Asian nations, the incidence of breast cancer is much lower than in the United States or Western Europe. These young women working in the fields of Sichuan province have about 10 times less chance of getting breast cancer in their lifetimes than American women. The big question is why? And if an explanation can be found, will it suggest a way of preventing the majority of breast cancer cases in the United States? There are so many differences between China and America that trying to pin down one that accounts for the different rates of breast cancer is enormously complex. But one possibility is easily eliminated, that there's a genetic difference. This isn't China, but San Francisco, and women of Asian descent who live here become as likely to get breast cancer as their non-Asian neighbors within a couple of generations. It's this simple fact that gives the greatest hope breast cancer can be prevented, because it implies there's something about the American way of life that greatly increases an Asian woman's risk of getting breast cancer when she comes here. Food is one obvious difference between the 2 cultures. Kong Su and her mother are preparing a typical Sichuan meal. Despite the pigs in the kitchen, meat and dairy products play a much smaller role in the diet here than they do in the West, and vegetables a much greater one. And despite the extensive use of stir-frying as a method of cooking, the amount of fat in the diet is far lower than in America. A typical American diet can have over 40% of its calories coming from fat, mostly in meat and dairy products, while a meal like this one has only 20 to 25% of its calories in the form of fat. So striking is this difference, it has long been taken as the most likely explanation for the dramatically different breast cancer rates between Asian and American women. The idea was strengthened by the neat correlation that exists between a country's dietary fat intake and its rate of breast cancer. And it was strengthened still further by the fact that rats fed high-fat diets have a high frequency of mammary tumors. So strong was the link between fat and breast cancer that the National Cancer Institute decided it was time for a massive human experiment.
Mid flank is clear.
What I'd like to point out is that we do not know that changing to a low-fat diet reduces your risk of breast cancer. There's a lot of studies out there that show
This is a recruiting session for what's called the Women's Health Trial. Its goal is to sign up thousands of women over the age of 45 and drastically cut the fat in their diets. In charge of the trial is Maureen Henderson.
I don't know how long women need to be on a low-fat diet before they get the full effect. But given they stay on it long enough to get the full effect, then we would hope that would cut the incidence by half.
Today is basically an information visit. So I would like you to take some time right now to read over this consent form, and if there's any questions, we can discuss it.
If they agree to sign up for the trial, these women will be assigned by computer to either a control group, who won't be asked to change their diet, or to a group who will try to cut in half their intake of fat. The study will require a total of 30,000 women, 40% of whom will be in the group required to cut their fat intake in half for 10 years to see if their breast cancer rate is reduced below that of the control group.
Humus, which would be kind of ground up.
These women in Seattle have been part of a pilot study to see how well women can stick to a very low-fat diet.
I found it really hard. The changes I've made have been for my breakfast and lunch. The rest of it I find very difficult. My social life is around eating. It's been a real consciousness-raising experience for me to see what I eat.
We had peanut butter sandwich.
Not me.
I had a peanut butter sandwich. And I was putting this on here, and she was telling me how many grams of fat I was having. I had a whole day's diet on one sandwich.
Blew it.
Oh, but it was great.
Oh, yeah. I smelled it, so that's all I did. I have a king salmon fillets here. There's a pound in
The women have been inventive in finding ways to have their intake of dietary fat. But while Maureen Henderson is confident the pilot trial has proved the full-scale study, which could cost $130 million, can be done, there are now growing doubts that it will be.
We believed at first that the toughest thing would be to get a group of women to change their eating habits and stick with it. We've now found that that isn't. That if you choose the right women and work with them the right way, that they will do it. They're marvelous. They will do it. In fact, what we've learned over 3 years is that there are very few major problems in carrying out the experiment. The problems we have now are with the people who advise us and who make decisions about going ahead, that they find it hard to believe that we can, in fact, carry out this experiment as we are doing, and they also find it keep on going back to the original rationale for the study in the first place and reconsidering it.
A big reason for the reconsideration is that several recent studies, including one of nurses, find no correlation between how much fat a woman eats and her likelihood of getting breast cancer. But the nurses mostly ate typical American high-fat diets. It could be there simply wasn't enough variation in their diet to cause any difference in breast cancer rates. In San Francisco and other cities, a new study is underway involving Asian American women. The idea is that some of these women probably eat low-fat Asian-style diets, others high-fat American food, and that the bigger range of fat intake will be enough to show up any difference in breast cancer risk.
When you were a child between the ages 5 and 11,
this is a case-control study. It takes cases of women who have breast cancer, then compares their diet throughout their lifetimes with controls, similar women like Maggie Chang, who don't have breast cancer.
Your family usually shop in the market or grocery store that sold mainly Chinese or Asian food, or one that sold mainly Western food?
So mainly Chinese food.
Between ages 12 and
The questionnaire contains detailed information on diet, but it also probes other lifestyle differences that might be relevant. Because if dietary fat isn't the cause of the big difference in breast cancer rates between America and China, something else must be.
By visiting the graveyard, by burning candles and incense, and by eating special foods.
In China, the old ways are changing. And so, too, is diet. Beijing now boasts its own Kentucky Fried Chicken franchise. And as westernization continues, the rate of breast cancer is rising. Is it because Chinese women are eating more fat? Or is it because there's something else about westernization that's increasing the breast cancer risk for the next generation? One thing that's changing is the typical teenage girl. Previous generations had their first period much later than American girls, became pregnant earlier, and had more children. All these factors have one thing in common. They decrease the levels in the blood of the female hormone estrogen. Estrogen is the hormone that in puberty stimulates the breast tissue to grow. Perhaps too much estrogen over a woman's life triggers the abnormal growth of breast cancer. The biggest source of estrogen is the monthly pulse sent out when a woman ovulates. So if the estrogen theory is correct, it's ovulation that is a major risk factor for breast cancer.
This basically determines your risk of breast cancer. The number of months and years you ovulate add up to determine why some women get more breast cancer than others. Now, what we would like to understand is what are the factors that alter how much you ovulate? How can we change how much you ovulate, particularly when you're young? And what effect will that have on your risk of breast cancer?
One thing known to decrease the amount a woman ovulates is strenuous exercise. A recent study found that exercising college athletes have half the normal risk of breast cancer, a discovery that would be predicted by the estrogen theory.
Now, we don't want, I don't think, to propose that every woman become an athlete of that level. But we were interested in whether more milder forms of exercise could have a beneficial effect in this regard. Would mild exercise during the early teenage years alter the rate of ovulation enough that it would have an effect on a woman's risk of breast cancer?
Brian Henderson turned to Los Angeles Ramona Convent School for help. He ran a study that found even mild exercise cuts the rate of ovulation among teenage girls. If the estrogen theory is right, these girls will be less likely than their inactive classmates to get breast cancer when they're older. Exercise keeps Chinese women of all ages leaner than the average American woman. And here is another way estrogen levels are affected. Because while most estrogen comes from the ovaries, some is made by body fat. So the thinner a woman, the less estrogen in her blood. This could be a way dietary fat contributes to breast cancer.
Fat's important because fat is a source of more calories per gram of food than carbohydrate and protein. But my view is that that's the way it works, that fat is not a cancer-causing agent in itself, but that as it contributes to calories, and calories are not burned off, that's how it causes breast cancer.
So is it dietary fat or simply being fat that increases breast cancer risk? The Women's Health Trial was designed to find out by substituting other sources of calories for the fat the women cut out. But growing skepticism about this and other practical aspects of the trial, plus waning belief in the dietary fat hypothesis, meant that in early 1988, a National Cancer Institute advisory board voted to cancel the trial. Maureen Henderson is disappointed.
Breast cancer, apart from lung cancer, is the most common cancer in women, probably the most lethal, and there has been no major study attempting to prevent one of the worst diseases in women. There's been several studies focused on coronary heart disease, which is a major killer in men, but there really has been no experiment tackling a major disease in women. And I think this is very important for the morale of a lot of women to go ahead with a study that will tackle one of the worst feared and most common diseases they face.
As the arguments continue over what causes breast cancer, a major study recently concluded in Falun, Sweden, has demonstrated that if the disease can't be prevented, its impact on the population and on individual women can be greatly reduced.
The real good news is that the most frequently occurring cancer in women, breast cancer, can be controlled. And not because of improvements in therapy, not because we found the cause of breast cancer, that is, we can prevent it. No, because we have a method that is very reliable, in good hands, with the help of which we can discover most of the breast cancers at such an early stage that the available therapeutic methods can cure the woman.
The method of early diagnosis is mammography, the use of low-dose X-rays to routinely screen for breast cancer. The technology is widely available, but here in Falun, Dr. Tabar has shown in a randomized trial that mammography alone, by detecting tumors often before they're apparent as lumps, can save lives. He's also developed a system of mammography that brings people from all over the world to learn.
There are many things that Dr. Tabar does quite different here than in the States, much different. The system is pure quality and quantity. The technologists have a system of positioning that is exact. Every move that you make has a reason, and you position the patient perfectly each time, or you do it again. The positioning that I've learned in the States is useless here. I thought I knew, but I knew nothing. 24.
Tabar's system includes detailed record keeping. Every woman in the county receives a notice every 2 years that it's time to come in for her regular mammogram.
Good.
Most women, around 90%, comply.
Vi har upptäckt en förändring i det här vänstra bröstet.
Women whose mammograms reveal a potential problem come in for a follow-up. Often the lump is benign. In others, the problem is indeed a tumor. Catching the tumor early, when the lump is still small and often undetectable physically, means mastectomies are seldom needed.
Case for breast conserving surgery. Mastectomy, in most of the cases, is unnecessary. Just lumpectomy, a portion of the breast with the tumor in the middle, has to be taken out. Or segmentectomy, as we call, wide excision. And also, probably in many cases, less radical other treatment methods, chemotherapy, are going to be unnecessary, and so on and so on. On a long term, there is a big chance that she's not going to die from that disease.
Early detection saves lives probably because the tumor has fewer years to shed its cells into the body, and the immune system is still coping. Dr. Tabar, between spreading the word on mammography and teaching his techniques to others, still finds time to read 2,000 mammograms a day.
You have to be a real believer in what you do, because reading 2,000 mammograms a day, and as I did in the past 10 years, I have looked at about 1.5 million mammographic films. You have to have a stamina, and actually you have to enjoy this intellectual challenge. And that's it. It's very simple. And you have to enjoy the result, of course.
Tabar's results suggest a high-quality mammography service, if attended regularly every year or two by every woman over the age of 35, can cut breast cancer mortality at least in half. If such a system existed in the United States, it could reduce breast cancer deaths from their current 40,000 a year to below 20,000. In many places, as here in San Francisco, an effort is being made to increase the quality and availability of mammography.
Hi, come right in here.
One barrier is cost. In Sweden, the mammograms are free. In the United States, they can go as high as $150.
And the charge is $40. Did you want to write a check or you want to use your Visa or
And in most states, third-party insurers are still reluctant to pick up the cost.
Come on in here. Thank you.
Another barrier to the widespread use of mammography is concern that the radiation can cause cancer as well as detect it. But today's machines use very low X-ray doses, and there is evidence that the breasts of older women are less susceptible to radiation than those of the young. Dr. Susan Love.
The risk-benefit ratio, the chance of finding a cancer versus the chance of causing one, alters somewhere around 30-35, where you're going to have more advantage than you are detriment. And so it really is worth doing mammography in women over 35, and it's not worth doing it in young women in their teens and 20s. Unfortunately, that message hasn't gotten out, and a lot of women still feel, oh, mammography, I heard that causes cancer, I'm not going to do it. And we really need to do a reverse PR program now to get it back into reality.
No. We'll get you one so you can feel like
3 weeks ago, Mary Ellen Toscano had her first mammogram at the age of 44. It showed a shadow that can't be felt as a lump. The question is it cancer?
What she has is this shadow here, and here's the wire that they put in an X-ray with the end of it right where the shadow is. So then what I'm going to do is make an incision, follow the wire down, and then take out the tissue at the end of the wire. These kind of lesions that we find that you can only see on a mammogram and you can't feel are usually the very earliest lesions. And so they're the ones that are the most treatable and curable. This is a procedure which 5 years ago we hardly ever did, and now we do quite a lot because people are having mammograms rather than coming in with lumps. They're having mammograms early, and we're finding them before they even get to the point of having a lump. Now, can I have a marking pencil?
The operation to remove the tissue was performed under local anesthetic.
And I know you're not numb. I haven't given you any Novocaine, and I know that, okay? So don't worry, I haven't forgotten.
Since the suspicious tissue can't be felt, the only way Dr. Love can find it is to follow the fine wire that was placed into it under X-ray.
Now, do you want to see or not see? You can.
Yeah, I do, definitely.
Here's the wire, and here's the tissue hanging off the middle of it. I told you it looked like chicken fat. I wasn't. I know. It's sort of gross, right? But the white tissue here is breast tissue. There's nothing in here that feels particularly bad or scary or anything like that. If this were cancer, there's a lot of ifs then. You have to get into, well, what size is it? And then you also have to get into looking at the lymph nodes before you can say absolutely the chance of cure. But by and large, if this were cancer, it would be an early, small cancer, and the chance of cure is somewhere around 80 to 90%. Yeah, it's actually pretty better than most people think. Yeah.
On the negative side, the fact that mammography is finding suspicious-looking tissue is leading to increasing numbers of operations such as this, which may prove to have been entirely unnecessary.
It may turn out to be an unnecessary operation. It's not too big a deal. It's certainly not fraught with risks and complications. And other than what I hope will be a very cosmetic scar, she won't have much except the memory and a little more peace of mind.
Hello? Hello. In Mary Ellen's case, the first quick check of the tissue by pathologist Jim Connolly confirms Sue Love's guess that it is probably normal.
It looks like an area of thickened breast tissue. It's probably normal. So it's really not at all suspicious.
Good.
There's still a chance that this is cancer, and I think the idea that you can detect it so early that she's giving you an 80 or better percent cure. I mean, that's a wonderful word, cure. No, I truly feel that I should have done it 4 years ago. You know, when they say begin at 40, establish a baseline, and know what your chances are, because high cause of death in women.
Breast cancer continues to be a major killer of women, and the fact that it kills slowly, often years after the disease is first discovered, means judging our progress against it is difficult. Only in the last 5 years has chemotherapy begun to be used widely. It's still too soon to see any effects it might have on the national mortality figures. And because chemotherapy still can't be accurately targeted at just those women who need it, its impact is blurred. Our hopes for understanding the reasons so many American women get the disease are still unfulfilled. There are many risk factors known to be involved: family history, age at first pregnancy, and so on. But the fact is, 70% of breast cancer occurs in women with no known risk factors. The one thing we can do for ourselves is to have regular mammograms. The American Cancer Society recommends a first mammogram between age 35 and 40, and regular screenings from age 40 on. As in the greater war on cancer, the battle against breast cancer is agonizingly slow. But never before have new insights into the basic biology of the cancer cell been so many, so detailed, or so quickly moved from the laboratory to the clinic. For NOVA's Battles in the War on Cancer, I'm Jane Pauley of NBC News. Good night. For more information on breast cancer, write National Alliance of Breast Cancer Organizations, 1180 Avenue of the Americas, 2nd floor, New York, New York, 10036. Or call 1-800-4-CANCER. Or contact your local American Cancer Society.
For a transcript of this program, send $4 to NOVA, Box 322, Boston, Massachusetts, 02134. Please be sure to include the show title. Major funding for NOVA is provided by this station and other public television stations nationwide. Additional funding was provided by Allied Signal, a technology leader in aerospace, electronics, automotive products, and engineered materials. And by the Johnson & Johnson family of companies, supplying healthcare products worldwide.